मेरे को चलाओ जूम रिकॉर्डिंग कॉपी कर देना बाद में। Okay, good morning to Washington, good afternoon to Portugal, and good evening to all Indian friends. I'm Dr. Professor Vivek Gupta. I'm sorry for 7 minutes late because I just finished an angioplasty. It was an acute coronary syndrome, and then I had a PP kit and everything to be taken off. So I was a little late. Can you hear me? Everybody can hear me?
Yes.
Namaste sir, namaste. Can I hear you? Can you hear me? मंत्री जी आप सुन सकते हैं सर?
मैं बैठा हूँ मैं।
Okay. So I will. नमस्कार।
मेरा गाँव एक इंटरव्यू है।
दिखा ना। स्पॉटलाइट दिखा।
हेलो।
हाँ नमस्कार। Okay, so I have to start my presentation. Okay, so good morning, good afternoon, and good evening. So this is the same style which WHO Director Dr. Andreas is speaking whenever he's taking a conference. Okay, so I am Professor Dr. Vivek Gupta. This is a 5th webinar in series. This is Indo-European hosted program, and I am thankful to Dr. Fayaz Shawl. Let me introduce. He's one of the oldest friend of mine. One of the very aggressive interventional cardiologists working in Washington University as a professor of medicine and cardiology. He has done almost all the type of interventions, including TAVI and everything. Then I introduced Dr. Fausto Pinto, who is my friend, and he's the immediate past president of European Society of Cardiology. And he's working in Lisbon, in Lisbon University. He's the head of department and dean of faculty, as far as my. Then I have to say hello to our minister, Honourable Minister, Mr. Ramdas Athawale ji. He's a Minister of Social Justice and Empowerment. He's based out of Bombay and Pune, but he's a good friend of ours, and he's working with Government of India and a good friend of our Prime Minister, Mr. Narendra Modi ji. Then we have Dr. Asokan, who is our friend from a long time. He will be speaking. Then Dr. Mohanan. He is a Cardiological Society of India President-elect, and he's from Trichur. He's the head of the Department of Cardiology in Trichur. Dr. Pk Asokan is from Kerala, Calicut. Then we have Dr. Mansoor Ahmad, who is joining in, and our friend Dr. Satyendra Singh from Bareilly. He is my batchmate and a good friend. He's an orthopedic surgeon. So as of now, we can see these people, and we have other people who join. Dr. Kalmath from Bombay, and Dr. Kalmath from Bombay. I think this is the whole list. Yes, okay. So Dr. Chinmay Gupta will give the vote of thanks, and Mr. Vineet Chaudhary will be singing few songs in the end. So let me start my presentation. This is 13th of May. I will share my screen. So the presentation is similar. Dr. Athawale Mr. Athawale has already seen, but I will try to reduce myself because then we have a Dr. Professor Shawl, and I want to tell you that this presentation is also live on the DocPlexus, which is a platform where more than 33.8 lakhs doctors are participants in that. Secondly, this presentation, this live webinar is live on Facebook Live on my side, and also live on Indians in Paris, which has 25,000 almost participants. How many will be joining, we'll come to know later. So we are thankful to DocPlexus to allow the streaming live on their platform, where 3.8 lakhs doctors are the participants. So coming back to my presentation, again, good morning and good evening and good afternoon. SARS-CoV-2, COVID-19, coronavirus disease. I want to tell you that I would be speaking a little more general because we have few participants on the Facebook, especially who are non-medical, for them to understand. So as of today, with May 13th, I forgot to introduce Dr. T.R. Raghu, who will be joining soon. He's the president of Indian College of Cardiology, which is another important body other than Cardiological Society of India. So as of today, 43 lakhs people are infected worldwide and more than 3 lakhs deaths, around 3 lakhs deaths from global perspective. India started screening a little later, but as of now, despite the best of the testing, we have 75,000 patients infected today. This is from WHO, and around 2,500 deaths, which is still a concern. India has, yesterday Prime Minister Modi ji had announced that they will be having a lockdown 4 from May 18, which will be a little different because there's some relaxation. But as of today, India is having around 3,000 fresh infections every day, which is not a good news in general. So coming to the American perspective, America is number one always, because as you see that the first important economy, and they have more than 14 lakhs patients infected and about 83,000 deaths. This is from today, WHO, just now live, I have taken the figures. Economic burden is, I have not taken the Portugal, which Dr. Pinto will tell us what is the situation there, but Dr. Pinto will talk more about the European perspective because he's the immediate past president of European Society of Cardiology. So I really welcome him, and he's one of the senior most person in Europe as far as cardiology is concerned. Yesterday only our Prime Minister announced 2 lakh crore package, which is 10% of our total GDP. And therefore, it is one important package which has been announced for the coronavirus disease treatment, facilitation of research, and of course to the poor people. And just now 3 lakh crore collateral free loans has been announced by our finance minister. This is just now. So coming to the presentation, this is just photograph taken just half an hour back. So we did a cath angiography and we did a ad hoc angioplasty. I would like to tell you that in our cath lab, Apollo Hospital has a protocol that they will admit the patients only when the COVID-19 test has been done, except for the very serious emergencies. So this patient was tested negative and we took in the cath lab. You can see the PPE, half PPE shield, which we were never using. I was in fact never using my even the face mask while doing angioplasty. As you know, all of the world, many people are not using face mask or even the head mask. So this is how we do it. So this is just now about half an hour back, we finished an angioplasty, tight lead-in with in the distal, mid to distal LAD was causing acute coronary syndrome, and after the stent, you can see, because this is just now half an hour back, so I thought let me share with you, and I immediately copied, I took a photograph with my mobile and copied on this PowerPoint presentation. So coming on to the disease, virus is a viral disease. It infects the lung mostly, and there are a lot of things coming up soon, and people initially said that it is only in the lungs, but now we all know that the virus is infecting the cells in a worse way, and coronavirus, it enters and replicates. It's S protein. It leads to antigen and antibody formation. And then the virus, after the entry enters, it translates into polyproteins and structural proteins, after which viral genome begins to replicate. Not going to major details, but I want to tell you that the vaccine is depending upon the antigen presentation, while antibodies are helpful for protection, whether it is a plasma treatment or it is a herd immunity. So this is all about this. Humoral and cellular immunity is similar like IgM and IgG production happens, and SARS-specific IgM antibodies, they disappear at the end of 12 weeks, while the IgG antibody can last for longer time. Cytokine storm is the end stage, and this leads to a lot of cytokines are released, and this leads to acute respiratory distress syndrome. That is why about 7% death in general, and more than 15% death despite the ventilation in elderly population. The cytokine storm will trigger a violent attack by the immune system and leads to ARDS and multiple organ failure, and finally lead to death. The clinical diagnosis is mostly because of the infection coming from cough and fever and dyspnea, but the most important diagnostic test is PCR test, and we all know that this test takes about 8 hours to 24 hours for the test to come. Real-time quantitative polychain reaction, this is the test which is done from the throat swab, from the respiratory secretions, not from the blood, while radiological diagnosis is coming from the CT scan, which is basically a ground glass appearance. And to tell you, that's very important, that sometimes, despite having the classical symptoms, patient may have a negative RT-PCR test. And in those tests, in those patients, this is auxiliary diagnosis because CT scan is always positive. This is what is there. So testing is key to success. As of now, India is testing about 1,100 people per million, while Germany has been doing the best. I don't know Portugal. Germany has tested about 25,000 people per million, while America has tested about 8,000 per million. USA, this is by PCR test. So as when you are testing more and more, in Delhi as such is testing about 1,500, but in general, India is testing about 800% per million only. Antibody test has come. NIV, this today news morning, NIV, National Institute of Virology, Pune, has developed India's first COVID-19 antibody testing kit. As we all know, Indian Council of Medical Research has actually returned the testing kit which came from China because it was too fallacious and faulty, and there were too many false negative and false positive tests. The Niti Aayog plans to make India COVID testing superpower with the private help, and they want to do at least 1.25 lakhs RT-PCR tests per day. The majority involve the use of imported kits as of 9th May news. Testing involves bringing scientists and laboratories in touch with the private firms. So not going to details, and this is the testing is rapid antibody test from China was found to be futile. It was returned back to China. It was a huge investment. Fortunately, government had not paid at that time. How the medicines work? The medicine, there is no specific medicine as of now. There is no specific medicine which can really kill the virus except for in vitro ivermectin. Just for the interest of the people who are audience who are non-medical, the virus inserted into the cells and at that point of inhibits TMPRS2, prevents viral cell entry, and hydroxychloroquine works at the level of membrane fusion endocytosis, while the important drug remdesivir, this works at the level of RNA-dependent polymerase. Coming on to the hydroxychloroquine, much hype was created when Mr. Donald Trump, who was actually a guest in India on 24th February, my birthday, later on realized that this is not the actual flu. Initially, he took it very lightly and he thought this is just a flu, so don't worry. But later on, he realized and he was asking and requesting our Prime Minister Narendra Modi ji to curb the, at that time, Indian government had done a curb on the export of hydroxychloroquine. So he requested and finally a lot of hydroxychloroquine was exported out of India. Let me tell you, there is some still doubtful. Indian Council of Medical Research about 3 weeks or 1 month back had actually announced that this should be used as prophylaxis for all the healthcare workers. Prophylaxis. And the dosage was very simple. This was the guideline came as I cannot read it, but I want to tell you the 400 milligram of hydroxychloroquine once only, twice a day, only for 1 day, and then followed by 400 milligram of hydroxychloroquine once a week for 7 weeks. This is the Indian Council of Medical Research guideline in India. A lot of healthcare workers took it, and there are still a lot of healthcare workers, because then there was doubt created by QTC interval by cardiologists that cardiac patients cannot have it unless you are very sure that QT interval is normal. So now today, as a cardiologist, I always do the ECG. If QTC is normal, we would allow the patient to take as a prophylaxis. But at the same time, I want to read, this is French virologist Didier Marseille. I will show you video. So what he said in this is a French study in February 2020. He was laughing on Chinese. He said this medicine should not be used. It's a more cardiotoxic. But at the same time, he started a study, and about 1061 patients from Marseille published on April 9. It shows that no major cardiac toxicity from this study. A good clinical outcome and virological cure was obtained in 91% patients, and death only was 0.47, the patient who were treated by combination of hydroxychloroquine plus azithromycin. So this was a landmark study, and therefore everybody started using, but there was some American study later on which came that this is more lethal. So not to go into details, but I would say that in Apollo Hospital, Delhi, even the Chinese study which was published in February, they said that in the absence of any major medicine against virus, this should be used with caution. And later on, FDA also said on 28th March that it should be used as emergency medicine. The patient who are not getting improvement and they are getting sick day by day. April 25, again, the US FDA said the similar thing. I don't know what Europe is showing, but I think they're following the guidelines coming from France by virologists saying that it's 91% effective. So leaving this part alone, hydroxychloroquine useful for prevention for healthcare workers and those who are on the field. While it should be used in all COVID patients, our hospital is using it. We have 81 beds. In Apollo Delhi, we have 81 beds reserved for COVID-19. And despite that, all the beds are full and we have a waiting list now. Role of ivermectin, only one word to say, this is an anti-parasite medicine which is approved by FDA, approved as a broad spectrum anti-parasite agent, but it is only in, this is the only drug which has shown high efficacy as an antivirus, but that is only in vitro. That means no human trial has been done, so we can't use it. Remdesivir is a very important medicine, antiviral medicine, recently approved by FDA, Federal Drug Administration, as important because the study has shown that this is very useful antiviral medicine, and the experimentally results are available. Antiviral medicine given by infusion previously failed as an Ebola treatment, but showed a promise against certain coronavirus in animal studies. Now it is approved as an emergency use by FDA. And remdesivir. Coming on to the mask, this is very important. I would like to give another 1 or 2 minutes because I'll have to finish in 5 minutes now because Honourable Minister will have to leave. I will take Dr. Pinto and then the Honourable Minister. And Dr. Fayaz Shawl, if he agrees, will like that. We'll see. So mask is very important. When it came in December 2019, people did not worry. In December, January, February, March, everybody thought March. When the March came, I'm talking of March 2020, people felt that mask is very important. And 26 March, my interview on television, I was little, at that time, nobody was allowed to say, there was no such meaning that everybody should use mask on the road. This is important for Dr. Fayaz Shawl to listen what I said on 26 March. So I said on 26 March, mask for everybody who is going out. At that time, there was no such guideline. So this was, I used the word amocha at that time, and very fortunate at that time. Later on, even Honourable Prime Minister used amocha, that everybody who's going out should be using it. It can be airborne. We don't know a symptomatic carrier. So we were not sure at that time, but at that time, I felt that this is important. So this was all about that. Mask, everybody has to use it. Vaccine in offering. Every day we are thinking that vaccine will come their day. A lot of young people, everybody feels that vaccine is the treatment. There's no doubt it's a preventive. More than 70 vaccines are being tested worldwide, 70 vaccines. But there is not even a single finished human trial. As of today news, it will take at least 12 months or 6 months, at least 6 months for having the vaccine to market it out. So not going to major details, there was a vaccine which came. What is vaccine for the interest of the normal audience? It is an antibody, antigen, which is injected as a preventive medicine like BCG or for polio or for cholera. And this helps in preventing the infection to be settled inside the body, something like herd immunity. Israel offered monoclonal antibody recently, but this still, they have not introduced into the market. Monoclonal antibody will be utilized for the treatment, not for prevention. But Italy has started recent trials, which was initially, this is updated on May 6. A team of Italian researchers claim that they have started the trial. But the most important trial, which human trial, the first to be started was Oxford University and Pioneer Oxford. Both scientists have said the vaccine is not expected in the market before 2 years, but the human trial have started, and that was Oxford. Today, Boris Johnson, yesterday has spoken, and he said COVID vaccine may be more than 1 year away. And he also said that Johnson has warned that in the worst case scenario, a vaccine may never be found. So this is a very bad news from where he's heard, and I hope that vaccine will come. This is today news. I taken the article from the morning here. So I'm not more. There are so many vaccines: Novavax, Biotech, Pfizer, Schengen, Moderna, Children, Emonio, Pharmaceutical, Casino. These are to tell you about the few things. Contact tracing. Coming on to the contact tracing app, I will request everybody who's listening that everybody should download this app on the mobile. This is one step ahead of social or physical distancing. Anybody who has got Arogya Setu app downloaded on the mobile will get if he comes in contact with COVID-19 patient, even within 14 days, the person will be able to know that this patient has got contact and therefore he should quarantine himself. Recovery trial is a very important trial for all the medicines coming up by the European study, especially for the antiviral medicines. Repurposed medicine. What do we mean by repurposed medicine? Repurposed medicines are those that mean the medicines which are already available in the market for some other purpose can be used and should be tried for coronavirus without having major antiviral studies. So new drug has been proposed by my father, Dr. M.L. Gupta, one of the new repurposed drug. It is pending in Indian Council of Medical Research. My father has been an active researcher. He has done more than 200 research papers. His research has still been today cited in Google Scholar Search. And this protocol, he is one of the repurposed drug without naming that, is still pending in ICMR to be used. And maybe a few days later, one of the repurposed drug can be used for this. Plasma treatment. For the sick patients, we take out the blood from the patient who is recovered from COVID-19. Antibodies are taken out and infused in the patient who is this. This is still investigational according to Indian Council of Medical Research, not used. We have still lost few patients despite plasma treatment in Delhi, but it is one of the big hopes, especially for those patients who are dying. Herd immunity is immunity which normally every virus gets it, and that has to be, this is the final answer. Stockholm, Sweden, actually is dependent upon this. I was told that they do not have a lockdown because they felt that let everybody get infected and they will have immunity. This is how the diagram shows that when everybody gets infected. But this is not true for this coronavirus COVID-19 because this is a highly contagious. Number one person can infect around 450 people, and secondly, it can kill a lot of people. It is highly infectious and it is a high mortality. So we will not depend upon herd immunity as far as my medical science says, and we have to have vaccine or some medicine which should actually be working. Ventilator treatment is very important for all the patients who become sick and they require it. We have isolation, ICU and isolation ward. Coming on to the healthcare workers, a lot of people have died worldwide. That is why Indian Council of Medical Research has said hydroxychloroquine should be used. Use mask, N95, take care, use PPE when you are directly treating the patients, and therefore we have to be very, very careful. Role of China. One professor, Tasaku Honju from Japan, Nobel laureate, there was a news which circulated, whether it was a fake news or it was a correct news. He said that this virus is actually man-made. And he said, even if I die, if I proved incorrect, I should be allowed that my Nobel Prize should be taken back. But later on, he himself withdrew. April 28, he said he never said like this. But of course, every day Mr. Donald Trump is accusing China that this is something. And since China is not allowing investigation, there's always a doubt that something is wrong. COVID and heart, I will not go into detail because this is the topic of others. My last slide will show that how many patients actually die when the patients have got high blood pressure or diabetes. When the comorbid condition is there, then the mortality is high. Let me find out. This is the last slide. With a patient more than 80 years, 8% mortality. More than 80 years, 15% mortality. With cardiovascular disease, 10% mortality. With diabetes, 7% mortality. So the mortality is very high. And this is despite the best treatment on ventilator in ICU. So we have to be very cautious of this virus. Still, the disease is not clear. People say that it is actually working in a different way. It is prothrombotic. It leads to acute MI. It leads to several other reactions in the body. It is not causing simple pneumonia. So finally, I really want to thank you for joining in. And if I see the time, this is 7:30 p.m. I'm stopping the sharing now. You can see myself. And I've been told that Honourable Minister will stay till 8 o'clock only. So I would request the Honourable Minister to stay a little more. And I want to have at least 2 international speakers to speak. When they finish off, then I would like your messages for the public. Is it okay for you, Honourable Minister Sahab?
Yes, yes.
मैं चाह रहा था कि अमेरिका के जो डॉक्टर है डॉक्टर फयाज शॉल पहले बोल लें, उसके बाद डॉक्टर पिंटो बोलेंगे, या डॉक्टर पिंटो पहले बोलेंगे यूरोपियन से, because it was in the serial with Dr. Fayaz Shawl, and then I would like you to speak. So can you stay till 8 o'clock with us? Okay, so I request Dr. Fausto Pinto to please come with his slides. I again want to introduce him. He's a personal friend, but he's a very big, very eminent scientist. He's a dean of faculty. He's a professor of cardiology. He's a past president of very important society, European Society of Cardiology, which has more than 25,000 attendees. When this conference is held every year in Europe, this time it is planned for Amsterdam. We are not sure whether it is being held or not. So welcome, Dr. Pinto. I'm unmuting you. You can share the slides.
Well, thank you so much. It's a great pleasure to be here, and again, thank you for the kind invitation. It's really we're living through different times and very complex. You just showed give a very nice overview on COVID and what we are facing globally. This is really it's not a problem of a country or a region. It's a global problem, although with some differences across the world. But at the end, we're all facing the same issues, and we're all trying to do our best to fight this very complex situation. I will try to give a little bit of an overview from a European perspective, and I'll be happy to share some data with you, and also in the discussion we can have a little bit more discussion on some topics that may be relevant for our meeting and for our discussions. We just showed the numbers, so I will not repeat that. Just giving you a little bit of the numbers from Europe. We had the first case in Europe was in France, was in January 25th. And since then, there's been a continuous increase in the number of infected patients. We do know that there was a difference among the different countries. It started very, very badly, particularly in Italy and Spain, and then France and the UK. Those numbers, if you look at the numbers between the different countries, actually they vary quite substantially, not only the number of infected people, but also the number of casualties, of the fatality rate in the different countries. And that has to do a lot, and we can discuss that, on the attitude that the decision makers, the government took in different countries. In my country, actually, we were affected a little bit later. So there was a chance to start some of the measures to try to contain the epidemic at an earlier stage. And our government, although a little bit slower than we would like, but actually took the measures that we as scientific community and medical community recommended the government to take. And I think that was the reason why we have a very reasonable situation in Portugal. We have actually, right now, we have about 27,000, 28,000 infected, and about 1,100 deaths, which is, of course, it's always not good to have casualties, but compared with Spain or with Italy or the UK, or even some countries that had a more open strategy, and you just what you were talking about herd immunity, and I totally agree with you, because I don't think that's the strategy for this kind of virus and for this kind of infection. And even if you look at Sweden, for instance, which was more relaxed and more based on this herd immunity, actually they have a very high fatality rate. They have over 3,000 deaths already. With a very high fatality rate compared with other countries. And even the UK, they started also with a strategy of herd immunity, and then they had to change, and very fast, but still, they're still facing very hard times with very high infection rate and very high also fatality rate, with over 30,000 people killed already just in the UK. Here you can see in this graphic, you can actually see the main peak average in Europe occurred in April. And now what we are facing is actually in most of the countries is actually a decrease in the number of infected people and also in the fatality rate in the different countries. And of course, as you know, there were very severe measures that were taken in many countries, like lockdown. Of course, all the different activities were very much closed. Not only the ones with gathering of large number of people, but even, you know, at the more local level, there were a lot of restrictions. Again, a little bit different from country to country, but overall, there were a lot of countries with lockdown. We had lockdown until just a week ago, and that was really having an impact in what you just approached as well, which is, of course, now getting into the next stage. This is not over, of course, but it's the whole issue about the economic aspects of this pandemic. Here you can see on the map the size of the circles has to do with the number of cases. And as I've mentioned, there is some heterogeneity across Europe with the main countries affected: Italy, Spain, France. Germany, interestingly, they have a high number of cases, but they have actually a low number, a low fatality rate compared with some other countries. And then, of course, the UK. And you can see here Sweden with a large number of cases and also the fatality rate, which is very high. Just gives you as today the numbers for the EU and UK. We still include UK in the EU. So we have over 1 million and close to 300,000 cases, and we have about 150,000 deaths. And again, this is for the 27 plus the UK. And you can see there the breakdown of the different countries. Again, in terms of casualties, UK is now the number one with over 30,000, 32,000, close to 33,000 deaths. Then Italy, France, Spain, Belgium, a very high rate also, a very high rate of infection and also fatality rate compared with some other countries. Now, at the ESC, at the European Society of Cardiology, we've been very much looking into this issue from the beginning. And on the website, and I'm just showing you here the website of the ESC, there is a section which is dedicated to COVID-19 and cardiology. As you know, and Vivek just showed that cardiovascular disease represents a very strong component in this process, not only because patients with cardiovascular disease, they can be more affected and they can actually be more easily infected by the disease, but also when they are infected, they also develop a higher rate of complications and the outcome is worse in patients who already have cardiovascular disease. So there was a lot of concern about these patients and about this situation. So ESC dedicated a whole section to this condition, and there's a lot of information. If you may have been there already, but if you go to the website, it's open access, so you have a lot of information there. And there was a document that was produced and basically provides guidance for the diagnosis and for the management, particularly focusing on cardiovascular disease during this pandemic. And it's very helpful because it's not only about how to treat cardiovascular disease in patients with COVID, but also it provides a lot of information on how to organize the Department of Cardiology in the setting of this pandemic. And I will show you just a little bit of that, and how to prioritize the type of procedures, the type of patients. So it's a very important, I think, document because it does provide a lot of information that can be very useful for us as cardiologists, particularly when we have to organize and we had to reorganize basically the whole hospital and in our case, the department to face the pandemic. And in this document, there's a lot of information that can be useful to organize this kind of changes. Well, you've seen already, Vivek showed, just to remind how the heart is involved in this disease. Basically, it can be involved in different ways. We know today, we know also there's a lot of things we don't know yet, but we know that the virus can not only cause a direct myocardial injury, and we know that when that happens, actually, as I will show you, the prognosis is more grim, is worse, but it can also have other kinds of involvement. Just the fact that in the cases of severe pulmonary disease, there is also an overload to the heart, and that's why patients with the heart condition, if they get pulmonary pneumonia or infection or overload or ARDS-like, they decompensate, and it's actually one of the reasons of decompensation is the involvement of the lung. At the same time, it can originate a fulminant myocarditis or some sort of myocarditis, and also it has been described the location of the virus on endothelial cells producing some sort of endothelitis, and that can actually be one of the reasons why these patients may develop some sort of thrombosis. We know that in some cases they can even develop intravascular disseminated coagulation. And it's also been shown that one of the reasons for decompensation is actually in some patients, they develop severe forms of atriolitis with development of thrombi, and that can actually be responsible for some of the decompensation and actually for the more severe cases that are affected in the lungs and then of course affecting cardiac function. Now, this just gives you a little bit of an idea of some of the algorithms that have been produced by the ESC, trying to help on how to face the whole situation. Here we have how to do the triage in patients who are admitted to the emergency room if they have a suspicion of acute cardiovascular syndrome or acute cardiovascular disorder. And again, basically the main concept, I will not go into all the details, but the main concept is to have separate circuits for the patients who have COVID or are suspicious of COVID and the other patients, because one of the things that we have witnessed, and this has happened around the world, is the fact that, of course, people are afraid to come to the hospital. So there was a decline in the number of admissions in the emergency room, and that we want to ensure that to our population that it's safe to come to the hospital. We have separate circuits, and the patients can come, and they should come if they have an acute event. Here we have for patients with the suspicion of cardiogenic shock and possible COVID-19 infection. This in patients with hypotensive, with large MIs or acute decompensated heart failure. And here basically one important aspect is for the healthcare providers, for us, always use the PPEs, because that's very important. As you know, there were a lot of colleagues and a lot of health professionals that have been infected. And again, it's very important the protection of the health care personnel to ensure that we impair the number of potentially infected people. So if the patient is in cardiogenic shock, then it should be treated as being infected. So all the preparation should be done in that direction. If the patient is not in shock, then there should be a confirmation of the COVID diagnosis first. Now, one important element, as I've mentioned, is the fact that there is a close correlation between the degree of myocardial injury and if that is assessed by troponin. And here we have the temporal changes in high sensitivity cardiac troponin concentrations from the illness onset of patients who've been hospitalized with COVID-19. And we see that the patients who had more severe forms of myocardial disease, and this is another study, so patients who had elevated troponin, these patients with or without cardiovascular disease, if they develop elevated troponin, they have worse prognosis than the patients with not elevated, with normal troponin. So as a sign of myocardial injury, the presence of myocardial injury is a sign of bad prognosis in these patients. Now, another important element that has been recommended is, of course, with this pandemic, there's been a change in the way that we use the different diagnostic elements, tests that we normally use. So in this case, there is a recommendation on the use of the non-invasive cardiovascular stress testing, and basically the indications, they have been much more, made much less because of, for instance, in terms of treadmill testing and so on, there has been indication that, for instance, stress tests in the treadmill for routine should not be used because there's the danger to create aerosols and to disseminate the infection. And here you have basically recommendations based on the regional involvement in the epidemic. So basically, if there is a severe involvement of the region in terms of the epidemic, basically there is inability to provide a normal healthcare, and this should be focused and rearrange the whole health system. And that's how it has been done across Europe, and I guess across the world, but across Europe, we've been organized in this way to face this pandemic. And here, again, not get into the details, but basically in this document, you have a strategical categorization, in this case of invasive cardiac procedures, where you have emergency procedures, and those should be done even in the setting of the pandemic. And then you have what have been classified as urgent, like non-STEMI, lower priority, like patients with stable disease, or elective procedures. So all elective procedures have been postponed, and the patients with low priority, they also have been postponed, and it should be performed within the next 3 months or so. And if it's urgent, performed within days. So meaning basically that the whole way that we are normally organized in our cath labs, in our the imaging departments has been changed. And these were basically the rules that helped us to shape our activity. And basically we developed protocols based on these indications in terms of what kind of procedures were done, what kind of patients were prioritized, what kind of basically reorganization of the department has to be done. Again, here for arrhythmic heart disease, heart failure, and other interventions. Of course, all the emergent interventions, those have been kept as normal, of course. Here is some recommendations for non-STEMI. And again, for STEMI, of course, the recommendation is for primary PCI, but for non-STEMI, the recommendation is only for the very high-risk patients to get into an invasive strategy, as we normally do. For the other ones, use a more conservative approach, again, according with the risk and the condition of the patient. And here for the STEMI, again, clearly there was a clear pathway that was defined, but these patients were treated as with primary PCI, particularly in the hospitals that have the ability to do 24/7 primary PCI. Because of, particularly in some countries, of the overwhelmed engagement of the hospital and of the ICUs, in some hospitals, fortunately, we did not face that, although we were ready for that. In my hospital, we did not face, as some hospitals in Spain or in Italy had to face, and they had to define criteria for admission to the ICU or for the ICU treatment, and even for ventilation, which mechanical ventilation, which again, this was important because in some places was a total overwhelm in terms of the number of patients that came to the hospital and potentially need to have this. And the recommendations for the patients with observed cardiac arrest and the patients on cardiogenic shock. And again, here also some recommendations for the negative patients or for the patients with suspected or positive virus. Now, for the management of chronic coronary syndromes, again, the indications during this period is for a more conservative approach and only revascularize the high-risk patients in case they are very symptomatic or if they develop some sort of complication. But otherwise, it is recommended that in patients with chronic coronary syndromes, the strategy at this moment should be conservative, optimal medical therapy, and to be conservative in only very specific cases to have an invasive procedure. Let me just share with you to finalize some data coming from Europe. This comes from Northern Italy, as you know, in the Lombardia, there was one of the most hit area in Europe. This is from the Marcometra's group in Brescia. And what it showed here was that there was, if you look at the clinical features of the patients and this was a group of patients that with COVID, you can see that particularly age, the presence of diabetes, of heart failure, and patients who had high SOFA scores, all these patients, they were at the high risk of developing complications. And here you can see, excuse me, you can see that the patients who died, again, they had a very high, compared with the patients that survived, very high levels of pro-BNP, demonstrating that they were more, of course, decompensated. And again, this shows that the patients who had previous cardiac disease, they had a worse outcome, so they had a higher mortality rate compared with the patients who were admitted in the hospital, but had no previous history of cardiovascular disease. So basically corroborated some of the previous data that we had from our Chinese colleagues. And here you can see, so you have here the patients with cardiac disease. They had a significantly higher mortality rate compared with the patients with no cardiac disease. Again, almost double the mortality rate in this group of Italian patients. Just a word on that, because there was a lot of controversy in terms of the use of ACE inhibitors or RAS blockers and the risk of COVID. This is a study that was just published a few days ago, and basically it's a large population-based study, and basically it showed, as was more or less our impression, that the use of these agents is more frequent among patients with COVID, because more patients with cardiovascular disease develop COVID, but there was no evidence that there was an increased risk in these patients. And actually, there are even some anecdotal cases and a few reports that show that there may even be benefit instead of increased risk. But this is one of the areas. There was another study that was published recently also that showed basically the same. So the use of ACE inhibitor, basically RAS blockers, renin-angiotensin-aldosterone system blockers, does not increase the risk of complications in patients with COVID-19. And this is from my country, was published by a group here from my university, and it shows something which is one of the concerns we have now, is the excess mortality due not only to the COVID, but particularly due to the other conditions, particularly by the fact that the patients don't come to the hospital, and the impact that this may have in terms of some of the chronic diseases or even some acute diseases that the patients may try to avoid to come to the hospital, and therefore they develop more severe complications. And basically they show, this is in black, is the mortality by COVID. This is an observation during about 1 month in Portugal, and there was a significant excess in mortality estimation, and this again probably due to the fact that again many of the other conditions are not being properly managed, and one of the reasons is the fact that patients are afraid to come to the emergency department or even to come to the hospital. And this black line shows the decrease from the beginning. We had our first case here in Portugal in the 2nd of March, and this is the number of admissions in the emergency department. So you can see a sharp decline in the number of patients coming to the emergency department. Now it's picking up again. For instance, in the first weeks, we had a decline of over 50% in terms of primary PCI, and we had basically the ones who would come, patients with acute MI, they would come late. We saw ruptures, cardiac ruptures, which is very unusual for us now to see in the era of primary PCI. And we also had some patients that came very late with more severe forms of heart failure due to acute myocardial infarction. We had a few patients that had to put on ECMO, and some patients that will have to, the ones who survived, that most likely will go into heart transplantation because they came too late in the process. So I would summarize this part of our meeting by saying that cardiovascular disease, as you know, is a major complication and cause of death in patients with COVID-19. Patients who have cardiovascular disease, they have a high risk, they have a high likelihood of being infected, and the presence of myocardial injury is a marker of poor outcome in these patients. And then cardiovascular departments, they have to adapt. We had to adapt during this COVID-19 pandemic. And at the same time, this pandemic has been responsible not only for direct mortality due to the patients that died of COVID-19, but also indirect mortality and morbidity. And this, we're still in the middle of the process. This needs to be further assessed. It just came yesterday, a paper from the UK, from Amit Banderjee, on the impact that this may have in the future, kind of a model to estimate the excess of mortality that we will be facing in the next few months. And certainly this pandemic affects everybody, and it's certainly in our field, in cardiovascular field, it's been one that has been very much affected and very much involved in the management of these patients. So I will probably stop here now and then be happy to have any questions and participate in the discussion. And I will stop now my sharing. Thank you for your attention.
Thank you very much for your very nice presentation, Dr. Pinto, one of the very leading cardiologists from Europe and Portugal. We have, I just welcome Madhvi Agarwal. She's joined us, and Dr. PP Mohanan is there. Madhvi Agarwal is a BJP leader from Kolkata. But I have been told that Honourable Minister has another meeting. He will join in later on. So I'm requesting Dr. Fayaz Shawl that if he allows me, that I would request Honourable Minister to do some social message, and then he will be listening, but he will be out of the video, but he will be listening to our talks, but the video will not be with him, but he will listen to all the talks of Dr. Fayaz Shawl and all. So I would request Honourable Minister to please come and join and give the social message on the screen. And I want to introduce my friend, Dr. Satyendra Agarwal. He's from Bareilly. He was saying hello to you. He's in Bareilly and orthopedic surgeon and actively involved in BJP. And Madhvi Agarwal is also listening. Thank you very much, sir, for coming and joining us and giving the morale boosting. You can tell what Modi government is actually is doing, and the 2 lakh crore package which has been recently announced. And we are listening to you now. You are unmuted. Thank you, sir. Sir, आप बोलिए. Honourable Minister, sir. Yes, आप बोलिए. I am requesting you to speak now. We are listening to you.
Yes. I am very happy to participate the second time in your video conference. And this issue is also very important issue. COVID-19 and coronavirus is also very dangerous for all over the world. Because you know that there was one First World War and Second World War was there. But now this Corona World War is Third World War. And you know that near about in all over the world, up to today, 2,94,000 cases are there, the deaths are there. And in our all over India, near about 2,533 cases are now deaths are there. And we are also fighting against the coronavirus, but this coronavirus is also very dangerous, very strong, and we are also trying to finish the coronavirus, but coronavirus is also going each and every area, each and every town. In Mumbai is also the capital of our country, as like as New York. New York is the economic capital of America, USA, and Washington is the capital of America. But now, today, Mumbai is the capital of coronavirus, and therefore, our Prime Minister, Honourable Narendra Modi ji, yesterday announced near about 20 lakh crore rupees for the small scale industry, footwear industry, and for the middle class people, for the developers, for the farmers, and for all. And therefore, our GDP will be go up to 10% after some days. And now economically, we are also we are not strong today because all the industries are closed, hotels are closed, malls are closed, and only all the economies are so stopped now. And therefore, the coronavirus is also very strong disease, very dangerous disease, and therefore we are also fighting against the coronavirus. The lockdown, the fourth lockdown announced by our Prime Minister Narendra Modi ji, because without lockdown there was no another alternative, because this coronavirus, COVID-19 is also very dangerous, and therefore Honourable Prime Minister Narendra Modi announced 4 times lockdown, and therefore because where there is a red zone, our Prime Minister announced going to take more time, but many delegates are also present here from USA, from Portugal, from Kerala, from Bangalore, from Mumbai, from Delhi, from West Bengal, and various parts of India. Many participants are also present in this conference, this video conference. And Dr. Vivek Gupta is the main organizer of this video conference. You are also the best doctor in Apollo. Apollo hospital is also very famous hospital in all over India. And therefore, I am not going to take more time. But job of our Honourable Narendra Modi government, we are also fighting against the coronavirus, COVID-19. And now we are also the PPE kits are also per day. There are near about 2 lakh kits are our factories also doing work, and every day 2 lakh PPE kits are also ready, 2 lakh masks are also ready, and therefore independently our India is also trying to fight against the coronavirus. And yesterday our Prime Minister announced 20 lakh crore rupees for all over India, and therefore Dr. Vivek Gupta, all the participants are also present here, and they will speak in your video conference. And on behalf of my Republican Party of India, on behalf of Supreme Justice and for the State Minister, one of the State Minister of Narendra Modi government, Narendra Modi is also very serious to fight against the coronavirus, COVID-19, and the world is also facing this war. This war is also very important war, very strong war, and therefore definitely we will win this war. Thank you very much, Dr. Vivek Gupta ji. Jai Bhim, Jai Bharat.
So let me introduce once again before he leaves, but I will request you to please keep listening. Your video may not be on because Dr. Fayaz Shawl is a very eminent cardiologist from Washington, DC. He will be now speaking, but before he leaves, I would like to introduce him again. He's the chairman of your Republican Party of India, but he has a meeting just now, and he has just pushed off his video, but he's very important and close to Honourable Prime Minister Narendra Modi ji. So now I am requesting, so I was just saying that I was introducing you further to our European and American friend, that you are very close to Honourable Minister, Prime Minister, and you are the Minister for Social and Justice Empowerment of Government of India, and you are taking care of so many people. As of now, he's in Bombay. He's based out of Bombay, but he's in his office in Delhi. Thank you very much, sir.
Thank you.
So may I invite Dr. Fayaz Shawl. He's not a name who would not, every cardiologist in India or the whole world knows him. And he is an Indian origin American cardiologist, if I'm not wrong in saying that. But he has done a lot of research, very aggressive cardiologist, and especially high complex cases he has been doing. And we all know him, we all learn from him. He's in Washington Adventist Hospital in Washington, DC. And I'm thankful to him for joining us. And he said he has to leave at 11 a.m. their time. But now I would request him to start his presentation. And also, if he wants, he can introduce himself once again. Sorry. We are trying to unmute you, but okay.
Okay.
Yeah, I can hear you now. Sorry for delay of 15 seconds.
Thank you, Vivek, for a wonderful meeting, and I thank you for your kind invitation. I know this is a very serious issue. We're all involved. We're all in together. So I'm going to focus myself cardiovascular involvement in COVID-19. I don't want to repeat what you said eloquently, and Dr. Pinto gave us a wonderful presentation. So let me go and share my slides with you. Okay. Can you see my slides?
Yes, yes, very good. Very nice. We can see well.
Okay. So I don't want to repeat, as we know that coronavirus has reached a pandemic level, and we know the cardiovascular issues with coronavirus. But let me focus what we know today about COVID-19 and cardiovascular issue. As of last night, in the United States here, we had about 1.3 million people with almost 82,000 deaths. Of those 82,000 deaths, about 1/3 occurred in New York. I live in Maryland and DC and Virginia district. We had here 64,000 cases so far with 2,900 deaths. But this is a global problem. More than 4 million people have died worldwide. And while efforts to contain COVID-19 outbreak continues, but some states, especially in the United States and some states in Europe, have shifted their focus towards reopening their economies. But let me tell you, I'm very worried. I think we're not ready yet to open the economies, and that may give us grave consequences if we open too quickly, as we still have cases every day. Now, as we know that COVID-19 causes predominantly viral pneumonia with additional extrapulmonary manifestations, and large proportion of patients, which we see here and around the globe, have underlying cardiovascular or they have cardiac risk factors. Now, the risk factors have been shown to be associated with high mortality, especially male sex, advanced age, presence of comorbidities, particularly hypertension, diabetes, and cerebrovascular disease. As Dr. Pinto mentioned earlier, that we see cardiac injury, which is determined by elevated high-sensitive troponin level, is strongly associated with high mortality.
Dr. Shawl, Dr. Fayaz Shawl, we are seeing your slide, only one slide. It's not moving.
It's not moving?
Yeah, it's not moving. We are seeing only the first slide, which shows CCBR.
Oh, let me do something here. This should be exit. I'm sorry about that.
Is there someone, you share the slides and then you have the mouse marker onto the slides and then it will move. Yes, it's better. Yeah. So we were seeing only first slide for
I'm sorry, I'm gonna, can you see now it's moving?
Yeah, it's moving now. It's moving now.
Okay. All right, so I'm gonna talk about here that with high mortality, you can see with a recent publication from the United States, over 4,000 patients with COVID-19, showing in US, the highest mortality was in patients with above the age of 85, 10 to 27% mortality. Between 84 and 65, 3 to 11%. From age 55 to 64, 1 to 3%. And less mortality between the age of 20 to 54. And there was no fatality in the US among 19 or below. So it's really the much elderly population who have high mortality. But there has been some recent reports from New York, few deaths among young kids, what we call pediatric multi-system inflammatory syndrome, PIMS, whether it's related to Kawasaki's disease or separate COVID-19 remains to be seen. Very disturbing that we thought that it's not affecting the young children, but we're seeing something new with COVID-19. And also a few publications on JAMA and Lancet from China suggested that COVID-19 can trigger acute coronary syndrome, arrhythmias and heart block, exacerbation of heart failure. This may be due to combination of severe systemic inflammation plus localized vascular inflammation of the endothelium at the arterial level. I want to also mention that when we have elevated troponin, it occurs in 10 to 30% of all hospitalized patients with normal coronaries, 10 to 30%. And when it's in ICU, 22% have elevated troponin level. So there are really, when they come, there are two types of cardiac injury. One is predominantly respiratory presentation, ARDS, abnormal chest X-ray, abnormal CT. But in this population is a progressive increase of troponin alongside of the biomarkers of systemic inflammation. As the biomarkers go up because of cytokine storm, there's more increase of troponin. Or it could be a predominantly cardiac presentation. Then you have EKG changes, which I will show in a minute, could be due to myocarditis or stress cardiomyopathy or Takasobo or through ACS. It just shows you here, this is from Roxanne Maron's slide. She recently presented that when we have COVID-19 and they have this cytokine storm, there's also increase in D-dimer, reduction in the lymphocyte count, increase in the ferritin level, and also interleukin-6, And you can see as the disease gets more worse, as Dr. Pinto showed, there's much higher increase of troponin. Higher the troponin, higher the mortality. This is an example of a patient who was just published in JAMA showing diffuse ST elevation in a patient with COVID-19, had normal coronaries. And the cardiac MRI showed hyperintensity suggesting interstitial edema with low ejection fraction. So having said that, what is the current guidelines for how to manage ACS patient in COVID era? This is the from the American College of Cardiology, ACC-AHA. You have to really look to, is a high risk ACS or a low risk or intermediate risk ACS? If it's a high risk ACS, of course, guideline directed medical management, and we'll do urgent or emergent angiography intervention. As I will talk in a minute, that in order to do that, you need a dedicated cath lab. Like here, we have 7 cath labs. One is dedicated to COVID positive or COVID possible. Because if you do testing, it takes time. And if somebody is unstable from cardiac standpoint, we take them to the dedicated cath lab, which is a negative pressure room with complete PPE. So that is when we do these cases in a dedicated cath lab. Now, if patient is a low risk case with ACS, we do only angiography and intervention if there's recurrent symptoms or decompensation. Similarly, in STEMI, if it's a STEMI patient, we really, and is through STEMI, we still go directly to the cath lab, whether they are COVID or no COVID. But again, it has to be a dedicated cath lab. And believe me, there's no role of thrombolytics in this robust care system unless you don't have it. Then I think you can give thrombolysis. But I'll talk in a minute. If you do thrombolysis, there'll be many patients you'll be giving thrombolysis with normal coronaries. Because also, as Dr. Pinto showed, we don't see much STEMIs. Where have they gone? In fact, this is the recent data showing 38% reduction in STEMIs in our area, in Washington, D.C. area. 38% reduction in STEMI in patients. This has been also shown in Italy, Spain, UK, Canada. There is marked reduction in the number of STEMIs coming now, even patients with ACS and non-STEMI. We don't see many of these patients. Now, where they have gone and why they don't see it? Well, it could be due to there's less pollution, less cars, less stressful situation. Patients are home, they have no jobs, there's lockdown, they're relaxed, there's less physical activity at home, more sleep, more time with the family, less stress. They are taking more medication. They're more compliant. But I can tell you that they are having some reports that patients are also afraid to come to the hospital. And there has been an increase in the number of cardiac arrests at home. In fact, there was a paper just a couple of days ago from New York. There was an 800% increase in cardiac deaths at home because patients are afraid to come. In fact, in the last couple of days, we have been seeing more coming STEMIs as we saw, say, 2.5 months ago. In fact, there's a North American COVID registry coming up, NACMI, in data in coming weeks to show you how we have reduced the number of cases during this COVID era. Plus, we don't do any elective cases, no elective towers. We only do urgent cases, which has been going on for the last 2 to 3 months. But we know when there is COVID, there's a direct myocardial infection by inflammation, myocarditis, endothelial dysfunction, and also atherosclerotic acceleration and activation and a plaque rupture and endothelial dysfunction, and also increased prothrombogenicity, causing both type 1 type 2 ACS, thromboembolic phenomena, strokes in young people. We had a patient a couple of days ago with a massive stroke, a 34-year-old patient with a massive stroke from middle cerebral artery. And there's also an element of DIC. This is an EKG of a patient a couple of days ago who comes with diffuse ST elevation with some right bundle, but he had family history, family had COVID, he had all the symptoms of COVID, and he had a cardiac catheterization, he had normal coronaries, but unfortunately, he did not make it despite ECMO. He was very sick. You can see the repeat EKG showing same changes. This was a series of cases from New York showing ST segment elevation in COVID patients. What was fascinating, that when you have normal coronaries, 40% had diffuse ST elevation. When you have true myocardial infarction, there's focal ST elevation, either as inferior, anterior, or lateral, while in patients who have normal coronaries and STEMI, 40% had diffuse ST elevation, 60% had focal ST elevation. But the key thing was doing echo on these patients. A segment of wall motion abnormalities, which were done in 9 on echoes, did not have wall motion abnormality. Whereas patients with true MI, 75% had true wall motion abnormality. Also, when you have a true STEMI, you have a much higher troponin level than patients who have STEMI but normal coronaries, but the mortality is high. You can see patients with true STEMI, with coronary disease and COVID, 50% mortality. But if you have normal coronaries, 90% mortality in patients with COVID when they don't have coronary disease. You can see here, these 18 patients, majority died, and you can see the timing of the EKG changes. Some people have EKG changes when they come in, or some people have EKG ST elevations later, as late as 6 to 7 days. So EKG may not be abnormal at the time of admission, but you can see ST elevation COVID patients with normal coronaries at a later part, anywhere from 4 days to 12 days, or in this particular case, at 11 days, there was an EKG changes. And one of the patients who had EKG changes in the beginning had heavy thrombus burden, and one patient had, again, a big thrombotic occlusion, got lytics, but he died 24 hours later. So in other words, is when you have a non-STEMI patient, they have conventional risk factors, and majority have non-obstructive coronary disease in COVID era. The potential mechanism of myocardial injury, I'm talking elevated troponin, is acute infection, triggering an intense myocardial demand, and a cytokine storm caused by severe inflammatory stress precipitating plaque rupture, instability. At the timing of angiography, as I said, we don't do angiograms with non-STEMI unless they're unstable, as we know that majority will have normal coronaries. Now, when it comes to STEMI, majority, as I just showed you, have non-obstructive CAD, but they have LV dysfunction, but they don't have segmental wall motion abnormality. They have more global LV dysfunction due to COVID-19 myocarditis or stress cardiomyopathy or Takasobos. Now, what is the impact of COVID-19 here in the US on acute MI? I think it is continuing to rise here as is worldwide. It has got enormous impact on healthcare system. As I said earlier, we have canceled all elective procedures. We converted outpatient visits to telemedicine and limited visitors to come to the hospital. In fact, anybody who comes to our hospital, COVID or no COVID, there's no visitation, there's no family in the hospital. I think there's no question the management of true STEMI is challenging because of the risk of exposing the personnel and patient to the infection versus the benefit of primary PCI. And I am not personally in favor of thrombolytics because the reason here we have a dedicated cath lab for STEMIs or patients who are acutely sick. Because if you give thrombolytics, and there's a risk of, because these patients have a history of stroke, they get hemorrhagic stroke. And also we know with COVID, there's multi-organ failure and cytokine storm, and there'll be more bleeding issues. And also, as I mentioned, that 1/3 of patients with COVID-19 will go to ARDS, and that therefore there'll be increased risk of alveolar hemorrhage in the lung using thrombolytics. And also, the ST elevation does not mean they have a true STEMI. So ST elevation can be because of Takasobo, myopericarditis, spontaneous coronary artery dissection. I think therefore we don't propose thrombolytics in patients with STEMI or when EKG changes looks like STEMI. Because also we know if you have a true MI and you get thrombolytics, which may increase the hospital resources. With thrombolytics, it works in 55% to 60%, 70% have reinfarction rate, and a very high mortality. So I'd like to conclude that management of STEMI is challenging in this pandemic area, while thrombolytics could be a good choice, but in many patients be contraindicated. Also, if you do an angiogram, there's a high probability that these people have normal coronaries. Non-invasive testing with careful use of personal protection may differentiate true STEMI from, because if you're true STEMI, they will have segmental wall motion abnormalities on echo. And also if they go to cath lab, as I said again, the personal protection equipment is very crucial. As you know, in European data, there were a lot of cardiologists who have died. So I think it is very important that if you want to take the cath lab, that there is personal protective equipment, as Dr. Gupta showed when he did this case this morning. That's why we have a dedicated cath lab for COVID-19. So I like to conclude that COVID-19 is associated with high inflammatory burden that can induce vascular inflammation, myocarditis, cardiac arrhythmias, and death. Effective treatment is really vaccines, which we don't have. And we don't have yet any good antiviral agents against this virus. Just quickly, hydroxychloroquine has been shown it is not effective. In fact, the FDA has issued a warning of serious complication, especially with people with underlying heart disease, to give hydrochloroquine or chloroquine. Although one of the, there is going a prospective study by Novartis on a large scale until we know more clinical data, we don't give hydrochloroquine here in the United States. As Dr. Gupta mentioned that this drug remdesivir is really shown that the time to recovery is reduced from 11 days to 15 days, 31% reduction in the recovery. And although the mortality rate was not different, there was a tendency towards lower mortality rate with remdesivir, 8% versus 11%. But larger studies are done. But as I said earlier, that in some patients who have serious cytokine storm with release of all these tumor necrosis factors, we have been using this inhibitor toxylamine B, is a drug given for rheumatoid arthritis. And finally, I'd like to share that I know that presently we have to do social distancing, wearing of masks, as Dr. Gupta mentioned. But the most importantly, you can see you can't touch these because you can get contamination from copper, cardboard, stainless steel, and plastic. Look at here, the half-life of virus with the cardboard is almost 4 hours, stainless steel 6 hours, plastic 7 hours. So it may be there for many hours. So it's very important that you don't touch these items, especially plastic. There could be a virus, so you have to be very careful. Besides social distancing, which is presently what we are doing here in the world, in the United States, wearing masks, but also cleaning these items and not to touch them, including your cell phone, which you should use an alcohol swab because you can carry a virus, get infected. Thank you very much for your kind attention.
Okay, so thank you very much for a very enlightening talk, especially the COVID-19 acute coronary syndrome, involvement of heart and everything. And so we will have a panel comments because we have a lot of questions. And then first of all, I would like to invite Dr. Yashpal Sharma from Chandigarh PGI Head of Department. He has just joined. Dr. Mansoor Ahmed from Pakistan has joined. He was already there. Madam Madhvi Agarwal and Mr. Vineet Chaudhary, who is our friend, and he will sing some songs later on. I would like to inform you that this is going part of collaboration with Docplexus, which has a 3.8 lakh doctors, and it will be it will be a sort of a repeat telecast or something like that on that website for at least another week or so. So we have a very important, it's being recorded on, and also Facebook Live by Indians in Paris, which is 25,000 people. So I was told that that Madhvi Agarwal would like to speak because she has to go. She's a media panelist. Then we'll take questions. She has a media panelist and she has to go to on the news now in 8:30 p.m. So you are just invited to say something briefly about the social message from Kolkata, active BJP worker and friend of many in the government. Madhvi ji, please.
Thank you so much, Mr. Gupta. Good evening, everyone. I just want to say that it is important for all is to be positive during this lockdown. The pandemic was really unexpected, and although it is a tough time for all, but being positive is only key. The entire world is fighting through this tough time, and nobody expected that the world may go through a recession that too this huge. In this situation, it is really important for all of us to be tough and fight through all the difficulties for a better tomorrow. Because I'm associated with BJP, so I just want to say that PM Modi ji has taken appropriate steps to fight the situation by imposing lockdown and keeping people confined. This has not only helped us to contain the virus, but the entire world has been appreciating our efforts. We really need to be a part of this battle and give utmost support to the decisions that are made by the government. So अभी जिस तरीके से लोग जो है, क्योंकि लॉकडाउन का समय इतना ज़्यादा बार बार लॉकडाउन रिपीट हो रहा है, तो लोगों में एक जो है वो डिप्रेशन ना आ जाए, इसके लिए ज़रूरी है कि अपने आप को रेगुलरली मोटिवेट करते रहें लोग। और उसके लिए एक मुझे लगता है कि इसके लिए भी हम लोगों को कुछ करना चाहिए, लोगों को मोटिवेट करने के लिए भी ऑनलाइन अगर हम लोग कुछ इस तरीके के प्रोग्राम्स चलाएं जो कि उनको अवेयर करें, तो ये बहुत ज़रूरी है। तो बस मैं इतना कहना चाहूंगी, क्योंकि आप बहुत अच्छा काम कर रहे हैं और इसी तरीके से आप लोगों को जो है कोरोना वायरस के लिए जो एक जानकारी है, सही जानकारी सब डॉक्टर पैनल्स के साथ में मिलकर आप दे रहे हैं, ये बहुत एक सोशल एक अच्छा मैसेज जा रहा है लोगों के पास। तो मेरी बहुत बहुत शुभकामना आप सभी लोगों को। और मैं बस इतना ही कहूंगी कि आई होप दैट सिचुएशन इज ओवर सून एंड थिंग गो बैक टू नॉर्मल। And thank you so much, Dr. Gupta, for inviting me on this online discussion. It was really great opportunity for to speak in front of everyone. Thank you so much.
Thank you, Madhvi ji, for your nice enlightening talk. And you have to go on the TV news, and we always appreciate the efforts of the social people to help us. So now I would go on to the panel discussion, but I think Dr. Mohanan will start because he was supposed to speak something. But I think the questions are ready with everybody now, with the two stalwarts, Dr. Fayaz Shawl and Dr. Pinto there. So we can have, I don't think anybody else has to share the slides. So now I request Dr. Mohanan to please come in and join and tell us and start the panel comments and discussion on what Dr. Pinto and Dr. Fayaz Shawl has already spoken about. We have a lot of queries regarding heart, regarding COVID, otherwise Cardiological Society of India. He is the president-elect of Cardiological Society of India, and he is working in Trichur in Kerala. And we have also Dr. Kalmath joined just now from Bombay. So I just welcome him again, and he will be speaking about the comments and give some questions to the authorities who are there live with us. Please come.
Thank you, Mr. Gupta, for the kind invitation. For the second time, I'm part of your program, and welcome, Dr. Pinto. Professor Pinto, incidentally, is the president-elect of the World Heart Federation also. He was the past president of the European Society of Cardiology. As you and, of course, both the international expert has dealt in detail about the cardiac aspects of COVID, I will just take a minute and touch on the, now you also titled today's session as the impact on the healthcare. So I will just be mentioning about that. Professor Pinto, to your, just like the ESC did the guidance to your members, the Cardiological Society of India also has came out with some position statements to help its members and otherwise with the how to tackle a STEMI situation in a COVID scenario, and how to tackle again the importance of continuation of ACE inhibitors, and ARB was again correctly mentioned and sent communicate to all its members about the usefulness of continuation and never ever stop those vital drugs. We also have a communique regarding the how to do the imaging, especially echocardiogram, which is a very private investigation, in fact, where the chances of spread is very high, where our ECHO sub-council has come out with a statement about how one should be taking care of these important investigations for the cardiologists. The Cardiological Society, just a minute about the impact, the adverse impact of COVID on the healthcare scenario, especially in India. And Dr. Shawl mentioned about the disappearing MIs. All of us have seen the decreasing number of cardiovascular events, no heart failure, no STEMIs. Now, practically, the National Health Mission of India has come out with a figure, which is almost akin to the published that Fayaz Shawl was mentioning about the 9 hospital report from New York, which was published recently in Jan, which said about 36 to 38% reduction in the STEMIs. It's almost similar. We don't have a authentic data, but the data from the National Health Mission and otherwise shows that There was an appreciable reduction in acute cardiovascular care, and that is a big adversary factor for the private healthcare industry in India. For your information, even though the COVIDs are being managed essentially by the public health institutions. Of course, in many other areas, the private healthcare is taking an active part, but we know that at least 70 to 75% of the patient health care in India is supported by the private healthcare. And the COVID, with his decreasing footfalls on the outpatients and the decreasing the number of, because of the compulsion, the lockout, and the government also said that don't do any elective procedure. So the private healthcare industry has suffered quite a lot. And also the same, on the one end, you have the decreasing revenue. And on the other end, you have the increasing expenditure. You have to increase your, for example, the usefulness of PPE. That's again a big toll on the healthcare industry. So one has to balance these, and I'm sure the Gupta was mentioning, and the minister also was mentioning about the 20 lakh crore support. I sincerely wish that the private healthcare also gets its sufficient support from the government. Sure, I mean, I think we can take up the questions now, Dr. Gupta. Your sound.
Okay. So there are 2-3 questions which have come from Doc Plexus, and then everybody who can speak and allow, and they can join. The one question is, are ACE inhibitors being prescribed to COVID-19 patients in Europe and US? I think Dr. Pinto can answer this. Second would be, what could be the reason behind the reduced number of STEMI case among the COVID-19 patients? What could be the reason? And secondly, in what way COVID-19 affected the future of cardiology practice? This is coming from Doc Plexus. And what are the guidelines for treating COVID-19 patients with severe hypertension in Europe? So I'll request Dr. Pinto to answer regarding those 2 questions, ACE inhibitors and regarding the number of STEMI patients going down and severe hypertension, guidelines for treating COVID-19 patients with severe hypertension in Europe.
Well, there was a very early recommendation from the ESC that the ACE inhibitors and ARBs should not be interrupted in patients who were being treated with those medications, and that fortunately we have data now to support that. And actually, there are even some reports that they may actually be in a way positive, in the sense that by blocking the angiotensin receptors, there were a couple of studies that showed that may even be beneficial, but at least they are not harmful. And that was very important, because I had a lot of patients asking, because there was a lot of rumors. As you know, there's been a lot of fake news around the whole COVID issue. And that's certainly something that we have to reassure our patients, and we've been doing that. And the current recommendation is, if the patient is on an ACE inhibitor or ARB, should not stop, and we should not change the medication for that reason. And I'm prescribing, as I used to do, if there is an indication for an ARB or an ACE inhibitor. So I don't think that's going to be any change in the way that we are managing hypertension regarding the use of ACE inhibitors and ARBs. For the STEMIs, I mentioned that also, and the colleagues also, in terms of the reduction of the number of patients coming, and that's a real issue. Excuse me, because the problem now is actually, and I think the main reason is actually the patients who were afraid to come to the hospital with acute events. And one of the things that we are doing now in the different countries and here in Europe, ESC, the national societies are very much having movies and going into the media to make sure that the patients get reassurance to come to the hospital so they can be treated timely. Because the other issue is not only there was an increase in the number of people dying at home, but also the people who come, they come late. As I've mentioned, we had patients coming with a week of evolution of an acute MI, and as we know, that's going to mean left ventricular dysfunction, heart failure, And there's actually a few registries and a few studies now looking at the impact of all these changes in terms of how this is going to impact on the patient profile in the future. My feeling is that we're going to have an increase of patients with heart failure, because many of these patients with either non-STEMI or even with STEMI, they didn't come. So now they probably have significant left ventricular dysfunction and they will evolve into heart failure. So that's my guess. So important now at this stage for all of us to reassure our patients that it's important to come to the hospital, call the doctor, and if there is an event, we have here in Europe what we call the green wave for acute coronary syndromes and also for stroke. So the patient can call this kind of a 911 kind of number that the patient calls, and it's very fast and it works very well. But if the patient doesn't call, nothing is going to happen, and there's going to be a problem. So I think it's going to be one of the issues now is how we're going to convince the population to trust again, to come to the hospital and to be so we can treat these patients at the stage that we used to do. What I used to say is, for COVID at the moment we don't have treatment, but for the acute MI we do have treatment. So it's a shame that we are not treating a condition that we can now treat. While the other one, it's important, of course, but it should not shy away people from coming to the hospital to treat a condition that we can treat.
I totally agree with you, because we are facing the same problem in Apollo Hospital, Delhi. Now the whole Delhi, the whole India knows that the Indraprastha Apollo Hospital is COVID hospital. That means we have already big number of patients. 81 beds are reserved, as I told you. And a lot of people, they don't want to come to this hospital because they feel that they will get infected. So as I told you that we are using the PPE kit otherwise, but we have different isolation area, but you can't change the psychology of the patient. And I totally agree with you that there may be increase in the heart failure patient, because if the acute MI don't come, they just keep treating themselves at home or to a clinical practice or somewhere. So it will be a difficult situation. I would now turn the mic towards Dr. Raghu from Bangalore. He's a president of Indian College of Cardiology, and he's head of department in Sri Jayadeva Institute of it's a university, and is head of department in cardiology. So Dr. Raghu has kindly agreed, and please give some comments, and if you have some question to the panel, please go ahead. So, oh, sorry, I have to unmute you. Just give me a second. Okay. Yeah, Dr. Raghu, please go ahead. He's a good friend.
Dr. Vivek, thank you for the excellent program. I attended the first one also. This also, it's almost, it gives clear ideas our practicing physicians and cardiologists. Probably I think we have to live with COVID now. As a Prime Minister tell, probably pre-COVID era, and it's going to be post-COVID era. And we should have dedicated hospital like you have probably in every city. There should be a COVID hospital, probably all these related problems, whether acute myocardial infarction, acute coronary syndrome, acute kidney injury, maybe patient who require dialysis. Probably COVID patient can be treated separately. I think probably we should start think future, probably you should have dedicated COVID hospital in all the cities. That may serve the purpose, because we have to live with COVID. Probably COVID will not go away, and practice is going to change.
You're right, because I was shocked to see the news item where Boris Johnson says, the Prime Minister of UK, who has been himself suffered from COVID and now recovered, he said that the vaccine may not at all come. So I would like to have the panel view that is it possible that all the vaccine, the human trial which is going on, that is it a small possibility that that may not be at all vaccine? Dr. Pinto, what is your thought process?
Well, nobody knows basically, but there is a huge investment. As you know, there's a lot of different companies, there's a consortia, there's a lot of investment now. There was a big endowment just a few days ago for research in this area. So, we're living probably the fastest time to try to find either a new medication or a new vaccine. We have an example where we could not manage to have a vaccine in HIV. We don't have a vaccine. We do have good treatment, but we don't have a vaccine. But I think in this case, it will be very important to try to contain the infection because, and it's not going to be through herd immunity. And I know it's going to be different in different countries. But for instance, the strategy now in some countries is trying to, using control testing, try to reduce the spread of the disease and try to contain it. And in some countries that has been possible, but with a change in the way people behave. For instance, now you mentioned the masks. Now the masks are mandatory here in my country for people going in public transportation, going into closed spaces, shops and shopping centers and that kind of areas. The way, and of course, social distancing and washing hands, all that sort of recommendations. So basically, it's going to, if you look at some parts of the world where they're practicing this kind of attitudes, they've managed to have good results. But the problem is that we don't still know what's going to be the long-term effect. And again, it will depend on the characteristics of the country. New Zealand, for instance, now, they apparently have such a low infection rate. They have an R, which is like 0.1 or something, that they probably are at the stage they got rid of the virus, although it's never going to be 100%. In other countries, it's going to be much more difficult. Denmark said today that they got rid of the virus. I don't think that's real, but if you have an attitude in the country to try to promote in the way people live, social distancing, mandatory use of masks, I think we'll probably be able to go back to a new normal, as we say now. It's not going to be, until we have a vaccine or a specific treatment, it's not going to be as we used to have before this, but we also have to adapt. And as some of you have mentioned, things will not be the same. And at least during this period, I think we have to try to help also the society to go back to some normalcy. And this has to do with the imposition of some rules different from what used to be. And for instance, countries like northern countries, they are much easier to have social distancing. They are used to that. In the south of Europe, for instance, people are used to hug, to kiss, to touch. And that's a completely different story now. People have now to just stay away from each other, to use masks and some sort of barriers to try to mitigate the dissemination of the virus. But it's going to take time and again, the strategies may differ a little bit from country to country, from zone to zone, because in some places it might be more wise to use a certain strategy, while in others it may be more difficult, and you have to adapt also to the circumstances that you are facing in your specific part of the world. Here we're trying now to deal with the situation using all these rules, trying to mitigate, trying to reduce the spread of the virus. Now we're going down in the number of cases. The hospitals manage in our country to always be able to accommodate all the patients that we had to admit. There was no rupture in the system, but because we have very strong measures. And the thing is, how can you gradually, and we are trying now to gradually open. So now we're opening a little bit. We're monitoring, we're assessing, we're doing a lot of testing. I think that's a key thing, because if you identify somebody, then you can isolate that person immediately. As you know, now you have ways to track, even by using the mobile phone. You mentioned that, Vivek, we have to do our best to try to identify people infected so we can isolate them, so we should mitigate the number of infected people. I don't believe in herd immunity, to be honest. I think actually can be catastrophic, particularly and just see what's happening in the UK, even Sweden. They have a fatality rate which is like 4 or 5 times the one we have, and I don't think human life is should be our primary goal. So again, try, and that's what we are trying to advise also our politicians and our decision makers, to go in a way that we go slowly, we go with not going openly. Of course, everybody would like to open the society again, but that's not possible. And it's going to be up to us, the medical doctors and the scientists and the medical community, to try to help the decision makers to go slowly. You saw, I don't know if you saw yesterday in the US, there was an audition with Fauci and some other people, and they were very clear. You know, in the US now is facing, particularly in some areas, very, very difficult situation. Maybe Dr. Shawl want to comment on this, but we really have to be prudent. We really have to be careful, and we have to impose, or to help to impose, some measures that can help to mitigate the disease and in a way minimize the contamination, the dissemination of the infection.
True. There are two questions more which one question is for Dr. Kalmath himself, and there is a question from Dr. Kalmath to everyone. The question from Dr. Kalmath, the BC Kalmath from UK, from Bombay, and he's asking to Europeans, and especially Dr. Pinto can ask here, what are the real qualities of PPE kits in Europe and USA, as we in India, everybody is selling PPE kits. Dr. Kalmath, you can ask directly. You are unmuted.
Yeah, Vivek, very beautiful conference, and I mean, good points. And because as you just showed me, you're doing a plastic, the PPEs sold in India are not the real PPEs. They're just the kits which are used for like HIV kits or like that, because the real quality of the PPE should be enumerated, because it's a huge risk to wear any PPE and do a primary PCR where COVID results are not given up. So I would like to really comment on really what are the crucial steps in selecting the proper PPE, and then little bit on donning and doffing.
Dr. Pinto, can you answer this? What are the protocols in your place regarding when you're doing angioplasty, even if it's COVID-19 negative patient? So how much risk is there? Because today negative can be positive tomorrow. So Dr. Kalmath is a very important cardiologist from Bombay Hospital in Bombay, and he's very experienced. His question is, how can we really monitor the quality of PPE when you are doing such patients, and the healthcare workers are actually at huge risk? So what's your say as far as Europe is concerned?
Well, here in Europe, all the PPEs have to be certified. So all the PPEs we use, they have to be certified by the national agency. So well, we hope they are okay. We had a little bit of a problem at the beginning. Was we had a little bit shortage, you know, at the beginning in some places of PPEs, not the quality itself, but the number. And there was a little bit of an issue, particularly in the first couple of weeks in some areas, and we did have some people infected, health professionals. Now it's okay. Now we have more than enough, and basically, you know, they are certified. So we hope they are good, and the fact that we don't have many people infected now from our health professionals. It's a sign that they work. Again, you need to have proper training also, particularly if you really use the full gowns and the full PPEs. But people go through kind of a training how to put them on, how to take them off. The risk is more on taking them off. You have to be very careful, as you know. So we go through education sessions for the health professionals. Not only the doctors, but also the nurses and the assistants and so on. And I think that's crucial. The way we treat our patients, and that was mentioned, it's the same. You know, any patient we don't know if he or she, if we don't have the result, then we treat as if it was positive. So, while we wait so if it's a stemming, we do of course, the procedure. We use full protection, but we do the procedure. And then the patient stays in an area which is isolated until we have the result. And it will either go to the COVID area or it will go to a non-COVID area. Just one comment that was mentioned. In some places, they had separate COVID hospitals. China, for instance, they did that. Here, what we did was actually to have, particularly for the big hospitals, to have a clear separation of COVID areas and no non-COVID areas. So what we call clean areas and COVID areas. And that was actually a very important exercise because we would separate the different pathways, circuits of the patients, patient flow, and so on, and even personnel, that there will be no mixing. Of course, you can have a guarantee 100%, but that was done I would say, in a very efficient way. And if you cannot have a totally separate COVID hospital, because even if you have a clean hospital, you never know if you're going to have some patients there that you have not tested yet, unless you have a good screening system beforehand, which might be difficult from a practical standpoint. So what we have done here, and I know in other places they've done the same, is actually to separate the circuits and have clear pathways for COVID, pathways for non-COVID, and kind of the gray areas where you have the patients that are still waiting for results or where you're not sure if they should go one way or the other. But they have separate pathways, and that actually helped to minimize the number of infected people and also to create trust in the population that they will be separate and there will be separation between infected and non-infected part of the hospital.
Thank you. Thank you. Before I move on to another question from Dr. Mansoor Ahmed, I will really request Mr. Vineet Chaudhary to stay on because we have to have some songs later on. But there is a question from Mansoor Ahmed from Pakistan. But before that, I will request Dr. Yashpal Sharma, who is our friend from Chandigarh, to have some comments or if any question. He is the head of Department of Cardiology in PGI, Postgraduate Institute of Cardiology, is a very important eminent place in India and research, and he is heading the Department of Cardiology there. So may I request Dr. Yashpal Sharma to have some comments or some question.
Thank you, Dr. Vivek. Very excellent this webinar as earlier, and very nice lecture. Although I joined a bit late, I was listening to Dr. Fayaz Shawl. Basically, Dr. Fayaz Shawl came to PGI and Batra Hospital with experience of COVID-1 and MERS, cardiogenic shock, more than 1,000 patient experience. This we have written to Indian Heart Journal also, and this European Society we are also writing to BMJ, publishing. In fact, last time I also told, we have to review our guidelines because the majority of the patients are infected. And during infection, if we go for primary angioplasty, the mortality is 70 to 80% in ST elevation. And in non-ST elevation also 50%. If you give them thrombolysis, or those who are not even for thrombolysis, NSTMI presenting late, terofeban and nicorandil, we treated 4 patients, and the patients, they are recovering, becoming COVID negative. Although this COVID-1, we have a lot of patients. So we published late presenter of cardiogenic shock also in Indian Heart Journal, and the results are really better. The mortality 30 to 40% with all comorbid diseases. Even if, as I told earlier, in the primary PCI, if you see the patient, all patients with infection were excluded. Now the guidelines are telling that futile prognosis, you should not interfere. So majority of these patients, they are having pneumonia, sepsis, other things. So we have to sparingly said that thrombolysis should be given to all patients. And this fear of this transmission, everything will get cleared because 4th, 5th day, the patient become negative if we treat them aggressively by 7 days. And the virus culture is not showing any organism. That is, after 6, 7 days, the infection is there. And WHO has said that treat the sepsis very early, which we were advocating early, that patients with cardiac diseases, they are very compromised. And if you treat not them aggressively in the beginning, they go into septic and cardiac shock. So that is our philosophy. Earlier also, we are writing to WHO also for this. We were advocating, telling in our clinical meetings everywhere. So far, this is our repeatedly lectures also, in webinars also, here also, because it is not in the books, but rescue angioplasty and blanket thrombolysis, wherever indicated, where contraindicated, also go for terofeban, moderate to high dose. Here, APTT has to be kept 2.5 times with heparin. So this is very hypercoagulable state. In bleeding, the bleedings are not there. There is a total thrombosis, and thrombosis in prostate, mesenteric, brain, cerebral, coronary. So here pathology is different. And what I remember, we are doing all angiography, angioplasty, our previous one. There is a total thrombus burden where no reflow used to occur. Those are the cases. If you give thrombolysis after do, thrombus burden is so less, you do angioplasty as normal. So this will change the whole scenario of cardiology if we review our guidelines critically and see everything. So everything, life of cardiologist, patient, healthcare workers, our health industry, everything will improve. So just we have to click a button towards thrombolysis and changing our strategy from primary angioplasty to sparingly angioplasty, which we have written today also to Indian Journal, giving reference of American guidelines, European guidelines, Chinese guidelines, very critical. We today have seminar with our all fellow colleagues. So there were connected PGI Lumina also today at 12 o'clock, 12 to 2 o'clock. So my this one submission is review our guidelines this one jointly, not American, European, Chinese, all sit together in a webinar and critically analyze. So that will be the change of scenario of our healthcare system and economy. Thank you.
Well, thank you very much, Dr. Yashwant. I would now request Dr. Mansoor to join who have asked.
Hello.
Unmute करिए अपने आप को, Dr. Vivek.
Can you hear me?
Sorry, yes, I'm sorry. Now, thank you very much, Dr. Yashwant. And now I request Dr. Mansoor, you had some question which came on the chat. So you can ask the question directly. He's a cardiologist from Pakistan, Karachi, our great friend. He's a very experienced person. He's himself doing some webinars for Pakistan Cardiological Society of India. So please ask your question and go ahead.
Yeah, I think can you hear me?
I can hear you, but there is a lot of, some buzzing behind it. Please go ahead.
Okay, I think it's a little.
The sound is echoing.
Present discussion is nothing to do with cardiology as such, but it's been intriguing me a lot lately. At what is going on? The number of cases are increasing all over the world, but the mortality is so variable in different regions. I thought maybe it's age, higher the age, higher the mortality, and that may explain the lower mortality in South Asia. But then, what about Germany, where the population is as old as anywhere else? So I was just wondering, is there any postulated hypothesis or something, or any good guess on this? You from Europe?
Have you understood the question? He says why there is difference in mortality in various locations.
Well, in fact, we don't know. Well, of course, some things are obvious. If you have a better health system, it's easier to accommodate some of these patients, and like the German system. But also the way there is a problem, because the way the deaths are registered, it varies a little bit from country to country, the definition of a death by COVID. There was actually a complaint by the Belgium government or health entities saying that they were basically considering everybody, so they will have a much higher rate of mortality, and it's true. So that's one explanation, is the level of the health system. And of course, if you cannot admit, if you don't have enough ICU beds or ICU space for these patients, it's going to be dramatic. The other thing we don't know is why some patients apparently don't belonging to some of the risky groups, they develop severe disease. We don't know yet. You know, we do know that there are some that fit into the high risk, but also we've had patients here perfectly normal without previous disease, anything, and they went into very severe disease, and it's not still unclear. Probably at something to do with some genetics. There's some data showing that probably that may play a role, but we don't know yet. But sure, this is the main reason why we cannot go into herd immunity strategy, because it's going to be the number, and that's what happened in Lombardy, Italy. Very good health system, but unable to accommodate all those patients. That's what happened in New York, what happened in some other parts of the world. where you had such a number of patients coming in that no system can accommodate that. And many people died because basically they could not be treated in reality. The other thing was in terms of, in some parts, in terms of the way old people was treated. And there were some places where some of these people were staying, and a lot of people actually died in these places. And in some countries, there was not a lot of, I would say, care with, and some people, old people, actually died without even coming to the hospital. So we don't have all the answers, but these are just some of the reasons why you may see some discrepancy between some of the countries. But the main one, and that's why we need to have some drastic measures to reduce the number of people infected, because otherwise, if you have this kind of avalanche of tsunami of people, then no system in the world can, even the best one, can accommodate all these patients. Vivek, I have to leave now. I have another meeting now, and I really want to thank you very much for this very kind invitation. It was a real pleasure to be here with all these colleagues. I've been many times in India, and I want to go back, so I hope the travel will be open soon. But I really enjoy very much, and I think this is the way that we as doctors like to communicate. Not only like this, of course, we like also to be face to face, but I mean discussing, showing different ideas, and also discussing some things that can help us, all of us, to treat better our patients, because that's at the end what we want to do the best for our patients.
I request Dr. Asokan, I request him to please say a few words before Dr. Pinto goes away, and then we'll have discussion further.
You're always welcome, Professor Pinto.
Sorry. Can you speak? Asokan, please speak. Yes, Asokan, go ahead. No. Yes.
Can you hear me now?
Yeah. Perfect.
So one or two questions, and see, there's a difference in European guidance and the guidelines actually prepared by CSI and the recommendation from ACC. All of them agree that STEMI patients, managing STEMI patients, a challenging task for cardiologists, and all patients should get a standard treatment care as an emergency procedure. No difference in this. The difference is which patient should be taken up for angioplasty, what should be the outcome of the primary angioplasty in COVID STEMI patient versus non-COVID. Is there a difference in the outcome when you do angioplasty in a COVID patients? One. Second, we know that if the coronary is normal after the angiogram, are we unnecessarily exposing the healthcare workers for COVID infection? So these two things. Third one is, are we getting STEMI patients late for this procedure? So what should be the outcome? Because these people are coming very late, or there's a delay in doing the procedure because of logistic reasons. So these are the three questions.
I'll just say very, very briefly that a lot of these things we don't know yet, in fact. What we do here is that STEMI we take to the room because we don't know. So we take every single STEMI, COVID, we take to the room. And we did not have a lot, actually, to be honest, here in my hospital. But if it is a STEMI, we don't hesitate. If it's a non-STEMI, we only take the high risk, compensates, or and we do not have a lot as well. So I think we still don't know exactly. We do know some data that was shown that some of these patients, they have angiographically normal coronary arteries, so it's more because of the myocarditis-like, and we know that that can be deleterious. But in my opinion, if it's a STEMI, clearly, I think we should take the patient into the cath lab, of course, with all the protections and all the what needs to be done. But I still will give the benefit of the doubt in these patients. The other ones, it's unclear, you know. And again, the strategy is more in terms of compensate the patient, and if there is a decompensation, or do a delayed invasive strategy. But I think there is still a lot of unknown in this type of patients. Now, I really have to go, Vivek. Thank you so much. Really appreciate. Great meeting. Goodbye, dear friends from India. All the best. Bye-bye. Thank you. Namaste.
Okay, so I have to go switch on to some other speaker, because we have Dr. Hari Sharma. He just joined from Holland. So would you like to speak something before we start our further program? Dr. Hari Sharma?
Greetings from Netherlands to all of you. I'm sorry I couldn't join you earlier. I was hooked up and I just listened very briefly in the last 5-8 minutes. So if you have particular question related to Europe or Netherlands, I would be happy to answer, because I didn't hear others, so I wouldn't be able to comment on anything on that. One thing which I would like to add is that Netherlands has done relatively well. Our curve is on decline with respect to the number of cases, the number of hospital admissions, and also the number of deaths over the last 1 week. The country is opening up, but we are cautiously working and using all our intellectual, what they call it, lockdown. So means that using all the steps which are necessary to prevent further infections. So in the buildings, in the public transportation, the masks are only used in the public transportation, but the rest is all people are maintaining 1.5 meter distance. The driving in the cars and all that, is very routine. Things are becoming slowly to so-called normal, but not really. There's a lot of worrisome situation with respect to the economy, because all the major public things are closed. No proper classes, no games, sports, because Netherlands is really a sporting country, so we don't have all the sports. Just some of the sport club are starting training and having them with a distance by putting kind of boundaries, but I think it's not really. The gathers are all closed, and the weather is improving as well. Yeah. So that's what I would add as far as the Holland is concerned. But I would be happy to take if anybody has particular question related to the mechanism or pathology or anything with respect to COVID. Yeah.
You can raise the hand.
Sorry?
I think there is no such question, because we had a long discussion since time.
Yeah, I can imagine because I'm really late. I couldn't join you people earlier, so I thank for recognizing me, because I thought maybe if it is still going on, so I was just trying my luck. If you guys are still on, I'll go and have a look, and I just listened few things. Yeah, yes. I thank Dr. Asokan, Dr. Gupta. I mean, you guys are doing great. This is fantastic platform which you have created, and having really intellectual discussions and exchanging experiences. I think this is very high time for doing so. Yeah.
Thank you very much, Dr. Hari Sharma. I think before we almost at the end of our session, but there was a question which was asked. I'm not able to see, but I will answer myself. There was a question to Dr. BC Kalmath from Dr. Mohan. who was asking a question whether the patient has hypertension and if he has a missed beat, what he should do is related to COVID. So my answer would be, because Dr. Kalmath is not here, I think he must be knowing him. That's why he asked the question. My answer to this is that missed beat is 1 or 2 missed beat per day is not a concern, but of course, Holter monitoring for 3 days or 7 days or 1 day will be a reasonable option. And of course, one has to rule out ischemia, if at all there in the condition, he should consult a cardiologist. So I thought, first of all, I would like to summarize the whole thing. This was a webinar 5 in the series of IECR. There we had Dr. Fausto Pinto, who is the president-elect of World Heart Federation, which I did not know, and Dr. Mohanan told me. Along with Dr. Fayaz Shawl, we had a long discussion, and then our minister, Honourable Minister, Mr. Ramdas Athawale, had a social message, followed by Madam Madhvi Agarwal, who is a BJP active worker from Kolkata. She had a social message, and Dr. Mohanan, and Dr. Yashpal Sharma, Dr. Raghu, everybody, Dr. Asokan, and yourself, Dr. Hari Sharma. We all had a good discussion the point and to learning. And I'm thankful. And this was Facebook Live on 2 platforms. One was from my side, from Apollo Hospital side, not exactly, but our Facebook. And secondly, Indians in Paris, where we had about 25,000 people. And this was Doc Plexus. So finally, I want to thank Doc Plexus, which is a platform with 3.8 lakhs Indian doctors. And they had done a live streaming of this on their website. And this will be repeatedly on live, so shown on the website for at least 2, 3, 4 days or 5 days. So I thank Dr. Kritika Dhingra, who was there all through with us. I think she's not available. If she's there, she can put her video on just to say thank from our side. And the academic session is now over. And Doc Plexus, they can, if they are interested, they can put off the streaming. If Dr. Kritika would like to say something before you leave. Then we will have a small 2, 3 songs, because it's very interesting. I think she is listening, but she's not able to put on the video. So I thank Doc Plexus to continue helping us. And next webinar will also be live on the doctor's platform. It's a very interesting platform. Yeah,
thank you, Dr. Vivek. Thank you, Dr. Gupta. And thank you to all the panelists who were a part of this discussion. Doc Plexus was really happy to have you on board. And we've got a great response. Thank you so much for having that.
Okay, thank you. Now we start our cultural program. Don't please go away. A lot of people are still Facebook Live. And Dr. Vineet Chaudhary, I'm always thankful to him. Last time also, he is a singer and a celebrity singer and fan of Amitabh Bachchan. And he's a very good, not only fan, but he's a close touch with Mr. Amitabh Bachchan. And he goes to meet him in his house. I think it's a Pratiksha. What is the name of the house? I don't remember. But so I would like to have 2, 3 songs sung by you before we finalize this, although it is very late, but this will be little enthralling to listen to songs coming from your mouth.
Thank you, Dr. Saab. Thank you very much. Today, when the whole world is suffering from this pandemic, you people are doing great job, and I am thankful to your type of people who are helping the mankind with your ability. So you people have asked me to do some songs for you. Definitely, I love to do. And first of all, I will sing a song of my favorite Amitabh Bachchan's movie, from movie Zamir. I think you like the song. Just wait for a second.
चलती रहे जिंदगी तुम भी चलो हम भी चले चलती रहे जिंदगी चलो हम भी चले चलती रहे जिंदगी ना ज़मीं मंजिल ना आसमां जिंदगी है जिंदगी तुम भी चलो हम भी चले चलती रहे जिंदगी पीछे देखना कभी मुड़ के राहों में घूमे मेरा दिल तुम्हें लेके बाहों में धड़कनों की जुबान नित कहे दास्तां प्यार की झिलमिल छाँव में पलती रहे जिंदगी तुम भी चलो हम भी चले चलती रहे जिंदगी। एक मैसेज आपके लिए कि जिंदगी हमेशा चलती रहनी चाहिए, चाहे कोरोना हो चाहे किसी प्रकार की बीमारी आए, लेकिन जिंदगी काम चल रहा है और चलाना आप लोगों का काम है, जिसके लिए हम डॉक्टर्स को थैंकफुल हैं। तो मैं आपको एक गीत सुना चुका हूँ, इसके बाद मैं एक छोटा सा गीत आपके सामने और रख रहा हूँ और आशा करता हूँ वो भी आपको पसंद आएगा। एक सेकंड। मेरी हंसनी कहाँ उड़ चली मेरे अरमानों के पंख लगा के कहाँ उड़ चली ओ हंसनी मेरी हंसनी कहाँ उड़ चली मेरे अरमानों के पंख लगा के कहाँ उड़ चली। आजा मेरी सांसों में महक रहा है तेरा गजरा, आजा मेरी रातों में महक रहा है तेरा गजरा, आजा मेरी सांसों में महक रहा है तेरा गजरा, आजा मेरी रातों में महक रहा है तेरा गजरा। ओ हंसनी मेरी हंसनी कहाँ उड़ चली मेरे अरमानों के पंख लगा के कहाँ उड़ चली। डॉक्टर साहब, थैंक यू वेरी मच। आपकी आवाज नहीं आ रही, आप शायद अपने आप को अनम्यूट कर दें।
बहुत बहुत बढ़िया, आपकी आवाज बिल्कुल किशोर कुमार जैसी है और we keep it up and we keep it. Just the final comment before I close it. Asokan, anything you want to say? And then Dr. Yashpal Sharma, and then Dr. Harir Sharma.
2.5 hours webinar connecting and excellent scientific feast. I think we all enjoyed and got a lot of information and from the experts in the field, and excellent song by the Mr. Vineet Chaudhary. We all enjoyed and thank you.
Dr. Yashpal Sharma.
In fact, in the last, my strong belief, which I am again telling, the shift to the primary, thrombolysis, followed by terofabin, infusion, nicorandil, preserve the myocardium, and that will be, shortly we'll be having press conference after the lockdown, and we'll be having helpline number also for here surrounding and even abroad. So that number we will be giving protocol and everything, because you know at this time, it takes so much time. So our data, everything we will be giving. So that will immediately change the scenario. But I tell you, economy of the country, nation, globe will immediately change if we can save all the cardiac patients as well as our healthcare workers. Spread will be very less if we can make the patient negative rather than mortality, because one mortality, there is 1,000 gets infected. When patient survives, there is only 1 or 2 getting infected. So that is another theory of stopping the pandemic.
I completely agree with you that primary thrombolysis, you know that we have only 60% chances of success with primary with thrombolysis and acute MI. But I think you're right that healthcare worker infection is also equally important. And
no, Dr. Vivek, 60% is just with this. Whether you give streptokinase or any new one, after 4 to 6 weeks, you start terofabin infusion in a low dose for 24 to 48 hours. Every 98% reperfusion that we will be showing, 98 to 90, no pain. And then you, after 4 or 5 days, you take by the time the virus is not there, or even at interval. So the thing is, it is such a belief that there is only 60%. If you give thrombolysis, after that terofabin, nicoran and all drugs, basically what was happening, if we are not giving all drugs and these 2B3 inhibitor, which we invented from our PGI only, very low cost, and that is working so well. In fact, there is a paper in the Lancet in November 2018. That paper should be reviewed. Primary versus thrombolysis rescue, follow this one. So I'm telling, rather than doing in a non-viable myocardium or in a flowing vessel where there is a slow flow and dye becomes more hypercoagulable state. So at that time, just try to have good hydration, sepsis control. Otherwise, all the patients are in futile prognosis. This one at this time.
You want to say something? You want to say something?
Yeah. And my last question is to Dr. Harish Sharma. I want to know how long this virus is going to last.
Yeah.
Anything from your side?
Yeah, Dr. Asokan, this is really a very difficult situation at the moment, because so far the data which has come out is not really kind of clue that this virus has got that kind of mutation or changing or weakening. It is still maintaining its replication in a very original form all over the globe. Therefore, right now, I think the treatment which are being like repurposing the drugs, from variety of sources which are already in the market, that is one current option. But also, you might have read very recently that the plasma therapy from the COVID patients is also being tried, and it's successful in majority of cases. So these things are in the process. But I think to answer correctly or to at least predict something about virus, how long will it be? I think it is very difficult, because the infection is continuing. The infection, the pandemic state of the disease is still continuing all over the globe. Only thing is that some countries are now getting into the kind of 3rd, 4th phase. Other countries have already gone through the community spread. Like, for example, in Holland, very small country, 17 million people. We did kind of, bit of community, what they call it, the herd immunity, as well as the prevention. So people above 60 years of age, they were mainly protected. They were, practicing very, very strictly. But youngsters, they did a lot of activities still out, and a lot of asymptomatic people, those who probably got in and they cleared the virus. So it is, I think right now, it is the immune system which need to be really geared up for all the people. Secondly, the repurposing the drugs to treat the people, the patient, those who are coming to the hospital. And thirdly, continuing efforts all over the globe for the vaccine, which are now working very hard. Day in, day out, people are working hard to get this vaccine out all over the globe. So that is, I think, the take at the moment. So we still have to wait and see. The virus will still be there for a long time. It's a very rigid virus because the composition is so tough that it will not go just like that. It will take time. That's my answer.
Thank you. No, not audible.
Yeah.
Yeah.
Dr. Pk Gupta, I just would like to say the vote of thanks, my son, and he is actively involved helping us. Just say a vote of thanks, and then we'll come back again next Wednesday. But Monday also we'll do a webinar for industrialists once again. But just
wonderful.
Just stay away, stay for a few minutes, Dr. Vineet Chaudhary, Mr. Vineet Chaudhary. Please go ahead.
Next time I will sing a song for you guys. I have also my mic.
Chinmay, just say a vote of thanks.
Yeah, and congratulate all the learned speakers and panelists present on this panel for a very successful webinar again. And I'm very thankful to Honourable Minister Ramdas Athawale and Dr. Fayaz Shawl, Dr. Fausto Pinto, Ms. Madhvi, Dr. PP Mohanan, Dr. Kalmath, Dr. Mansoor Ahmed, Dr. Kritika Dingra, Dr. Raghu, Dr. Asokan, Dr. Hari Sharma. Thank you for joining the discussion. We welcome all the feedbacks and will inform the dates of the next webinar. I also thank Mr. Vineet Chaudhary for his musical participation. Looking forward to have everyone in the next session. Thank you.
So actually next webinar is already planned. This is, every Monday we are doing webinar for industry.
Facebook message.
And every Wednesday we'll do for American and European cardiologists. And this time will involve Kenya, Africa, Nigeria and Kenya also. So Asokan, any last comment, or we just finish off the meetings only 2.5 hours? Dr. Sharma, I'll take you next time for the song. Are you very much keen, or we can?
I'll do it probably next time is better, because now it's too late for you guys in India. I'm very geared up, but I think you guys, it's very late for you. So let's do it next time. I'll prepare myself and justify my singing.
Okay. Next time we'll take it next time. We'll take it next time.
Okay.
I congratulate you, Dr. Gupta, for the fourth seminar, webinar, or fifth? This one.
Fifth.
Fifth one already. Sixth one is on Monday, and seventh will be there. So we have to keep various different speakers.
Wonderful.
Okay, thank you very much.
Very nice. Bye.
Bye. Thank you. Bye. Namaskar. I think, sorry. Should we end the meeting, Asokan, now?
Yeah. I think only few of us now.
Okay. We'll see the next week. How to end the meeting? End meeting for all.